Aloha and welcome to our lecture today. We are going to spend some time learning about chronic obstructive pulmonary disease. In the clinical setting, you will hear this referred to oftentimes as COPD, COPD, COPD. Well, this is what the letters stand for. Chronic, as in it's happened over time, it's gotten worse and worse, and it's not going away. Obstructive, as in there's some obstruction to the airway, to breathing. Pulmonary, as in our lungs. And disease, meaning that this individual has a chronic lung disease. Okay? We often take care of these individuals in the hospital and in the long-term care setting. There are also patients who frequently come to our primary care clinics for treatment because this is a lifelong disease. Once people have chronic obstructive pulmonary disease, it becomes something that they deal with for life. So what really is it? When we talk about COPD, we're really talking about a group of diseases that cause airflow blockage and breathing related problems. So this includes emphysema, which we'll talk about, chronic bronchitis, and in some cases, asthma. Now, we spent a little time talking about asthma previously, but today we're going to more focus on emphysema and chronic bronchitis. So, statistically speaking, individuals with less than a high school education have a higher incidence of COPD. Individuals who are divorced, widowed, or separated, current or former smokers, and people with a history of uncontrolled asthma. So like we said, sometimes asthma is included in the COPD grouping, and now we see here that it is specifically those who have a history of asthma that has been uncontrolled for a long period of time. People aged 65 to 74 years old and older than 75, American Indian, Alaska Natives, and multiracial non-Hispanics, women, individuals who were unemployed, retired, or unable to work. So these are all individuals who have a higher incidence of some type of chronic obstructive pulmonary disease. So in emphysema, what we've got is air sacs are destroyed, making it progressively more difficult to breathe, and almost daily coughing and mucus production. So when we talk about those air sacs, we can see here another word for those is the alveoli. And we can see in this image that we see normal alveoli at the end of our bronchioles. And then in emphysema, we can see that these alveoli are dilated, or they're like overstretched, okay? And what happens with this overstretched alveoli, the air gets trapped. And so that old air cannot get out. Okay, so it's at this level that we're supposed to be having a gas exchange, right? And when that air is trapped and it can't get out, then what happens is new air cannot get in, okay? And we've got this damage that has taken place. So in this image, we're just blowing it up and we're looking at just one air sac, which we would refer to as an alveolus. Just one, alveoli is plural, and we can see here that there's mucus, we have an airway that is definitely constricted, and we've got problems with airflow. In these individuals with emphysema, they tend to look more like the individual you see seated here. He's kind of in that forward leaning position. We're going to talk about that in a little bit. It's that tripod position, which helps him breathe a little better. We can see that he's using some of his accessory muscles for breathing. They tend to have retention of carbon dioxide. Pursed lip breathing can, actually be helpful to them. Prolonged expiratory time. These folks often will speak in short, jerky sentences. They tend to be thin, and they are at risk for having heart failure, cor pulmonale, which we will talk about here in a little bit. But before we do that, I want to talk a little bit about CO2 retention. So I've talked about this before, but I'm going to talk about it again because I don't think we can talk about it enough when we are studying the respiratory system. What stimulates us to breathe? Do I think to myself, oh, I feel like taking a deep breath? No, it's automatic, right? It's my autonomic nervous system that controls my breathing, not me. I don't decide to breathe. But what stimulates it? Okay? And you might say, well, I guess if I held my breath long enough until I started turning blue and got dizzy, that I would need to take a breath, right? We could do that. It's really CO2 accumulation, right? Carbon dioxide accumulation is really our major stimulant of the respiratory center, okay? Now, some COPD patients build up a tolerance to this. So in other words, they have high levels of carbon dioxide in their blood, and it doesn't necessarily stimulate them to breathe the way it would normally stimulate us to breathe because they've kind of built up a tolerance to it. So we call them CO2 retainers. And COPD patients that develop a tolerance for high CO2 levels, in theory, their drive to breathe takes on another level, which is really hypoxemia. And what that means is that they've got low levels of oxygen in their blood, all right? So that's different. And we're going to define these here in a minute. So administering high doses of oxygen to these individuals may actually decrease their respiratory drive and cause a carbon dioxide-induced narcosis, okay? So we've talked about this before. We talked about it when we were looking at oxygen therapy. We said that it was important in a CO2 retainer to start our O2 therapy at a lower flow rate, whatever the lowest rate we can start them at that helps them to titrate their O2 levels to maintain a saturation of 92%. And you might say, well, wait, Mary Farmer, earlier you said that a normal SpO2 was 95% or above. And yes, that is true in an individual who has normal lung function, okay? Someone who has a chronic obstructive pulmonary disease might have an SpO2 of 92%. That's where they live. That's normal for them, okay? So if we can put them on an O2 flow rate that keeps them at 92%, that may be an order that the physician actually writes, okay? So this requires very careful baseline assessment and ongoing assessment of not only their vital signs, but their mental status as well, right? Because if they are retaining CO2 and they are not having this respiratory drive, what will happen is that CO2 will build up and they will go into what we call a narcosis, where they will become stuporous. They will be unresponsive. They will be more than confused. They will appear very lethargic and they will be very difficult to arouse. okay? Now, on the other hand, it's important to remember that we never want to withhold oxygen from a patient who is suffering, right? So you will oftentimes see nurses and CO2 retainers arguing about increasing the level of oxygen. The patient wants their level to be increased. The nurse is afraid that they're going to have an episode of narcosis because the oxygen level is too high and their respiratory drive is going to not, kick in. Here's the thing. It's really important to involve the physician and the patient and the nurse and the family in these conversations, right? And again, it's important to monitor your patient. So let's say you do go ahead and increase the oxygen by a liter or two. What is your responsibility as the nurse? To monitor them, right? I mean, what's the solution if they start getting a little bit loopy, right? You just pull back on the oxygen a little bit, all right? So we have to remember that our assessment skills are very important in dealing with these patients. So, chronic bronchitis is different. It looks different. These individuals have more of a cyanotic color. They have recurrent cough and sputum production. They tend to be hypercapnic and acidotic, and we're going to talk a little bit about that. They're more edematous. They have an increased respiratory rate, and they are also at risk for getting this heart failure, cor pulmonale. And so we're going to talk a little bit more about all that here in a few minutes. But in chronic bronchitis, this is what we see, air tubes that are narrowed. It's a result of the swollen tissues, excessive mucus production. We've got this hyperinflation of the alveoli, and we've got this air trapping again. And so another sign that you might see in these individuals is called clubbing of the fingernails. And look for this. I want you to look for this as an assessment in your patients with chronic obstructive pulmonary disease. This is associated with diseases of the lung. The cause of this clubbing is not fully agreed upon. They think it has something to do with growth factor secretion, prostaglandin production, and some kind of vasodilation that causes clubbing of the fingernails. And so I've used some words in the past few slides that I think we need to take a few minutes to define. So we're going to do that right now. So we talked about hypercapnia. We said that these patients have a tendency to become hypercapnic. Well, what exactly does that mean? Well, what that means is CO2 or carbon dioxide accumulation. Okay, so normal levels of CO2 are 35 to 45, and so we're talking about a carbon dioxide toxicity or a level that's above 45 millimeters of mercury. And we said these individuals could become drowsy, confused, they could complain of a headache, they could become dizzy or just unresponsive. Okay, this is becoming hypercapnic. This has to do with levels of CO2 that are accumulating in the bloodstream. Okay, the other thing that we mentioned was the word hypoxemia. And what hypoxemia means is low oxygen levels in the blood. So not enough oxygen. So we said a normal range in a healthy individual is 95 to 100%, and we really do define hypoxemia as oxygen levels that are going lower than 95%, even though we might have someone with COPD that lives around 92%. That's their normal, that's their baseline. Okay, so hypoxemia, low levels of oxygen in the blood. Now, there's one more term that we will hear used to describe these individuals, and that is hypoxic. The patient has hypoxia, okay? The definition of hypoxia is decreased O2 at the level of the tissues or in the organs. So what we're saying when the patient becomes hypoxic is that they are under-oxygenated at the level of the organs and the tissues and the cells, thus impairing normal metabolism, okay? So because of our decreased O2 levels now, it's impacting our body's ability to function normally, okay? So pulmonary hypertension is something that can happen in these patients, and it has to do with these airways that have become constricted, all right? And this pulmonary hypertension can lead to heart problems. We mentioned before this cor pulmonale. So pulmonary hypertension and COPD lung dysfunction can cause damage to the heart. So here we can see in these two images, we see the wide open blood vessels, and we see the normal heart and the normal right ventricle. And then on the opposite side, we see in pulmonary hypertension, we've got constricted blood vessels, and we have dysfunction in the right ventricle. And more specifically, what we see is enlargement of the right ventricle due to high blood pressure in the lungs caused by chronic lung disease. We see this dilation, this stretching of the right ventricle, and hypertrophy, which means overgrowth of the cells. So when you look at the image right here, you can see that the ventricle is thickened. The wall of the ventricle is thickened. And we might think, oh, well, if the muscle is bigger, right, then the pump, the heart, should be working even better. But in actuality, stretching out of that space and overgrowth of tissue in that space leaves less volume for blood. And so if there's less volume of blood in the heart, then guess what? Less blood is going to be ejected out into the body, okay? And so this is actually not a good thing. This is right-sided failure due to lung disease, and this definitely causes more complications for these patients. So, what causes these conditions? We know that tobacco smoke is a key factor in the development and progression of COPD in the United States, emphysema in particular. And we're also finding out more and more that vaping also causes lung disease. And so we need to be aware of this, and we need to educate our patients about this as well. We know that exposure to air pollution in the home, in the workplace, and the environment is also a cause. We know that in developing countries that poor air quality inside the home in particular does contribute to the development and progression of COPD. And you can see here what a kitchen looks like in a third world country, and you can see how the smoke clearly could be causing irritation of the lungs. I would fail to be remiss if I did not mention that sometimes COPD can be a genetic disease, and there is an ancestral component. Genetic factors can contribute from one person contributing this genetic to their offspring, so that their son or daughter is a higher risk for developing COPD in a situation where they don't have any other risk factors, right? They have developed COPD because of their hereditary genetic factors. some of the complications clearly are that there's going to be activity limitations, difficulty walking or climbing stairs, difficulty working, keeping their job, right? Oftentimes these folks will end up unemployed. They're easily fatigued. Simple activities of daily living can be exhausting for these individuals in the late stages of COPD. They might have increased confusion. They might suffer from memory loss. And so this is another complication that we see. More emergency room visits or overnight hospital stays. We refer to these folks sometimes as frequent flyers, meaning we see them get admitted frequently for this problem. But then they also have these other diseases and comorbidities associated with, like we mentioned before, the heart failure. They also may have arthritis, like the heart failure, congestive heart failure, diabetes, coronary artery disease. They can have histories of stroke, or they could have a history of long-standing asthma that was not controlled. We have to keep in mind that when you look at all the things we just mentioned, inability to work, inability to perform activities of daily living, not being able to engage in their usual social interactions, going to church, going out and shopping, being with their friends and their family can lead to depression and other emotional conditions. So we want to be aware of this as well. And so what are we going to do about it? Well, the treatments are very similar in some cases to the treatments we've talked about with other respiratory illnesses. Our bronchodilators are going to be important. These drugs can help relieve the coughing, the shortness of breath, and the breathing problems by relaxing the constricted airways. So we can use albuterol, which is our, remember, way back from when we talked about this in the asthma lecture, we said that the albuterol was the activator, right, of the beta-2 receptors, which opened the airways. We can also see here our Ceravent, or our salmeterol medication that can help open up our airways. And then also our steroids. Our steroid inhalers are going to help reduce inflammation. It's going to be important to use them together in combination with each other. We always have to remember, though, that after steroid inhalers, we want to rinse out that mouth to prevent oral thrush. Sometimes we can use a combination drug that has salmeterol and steroid in the same inhaler, and this can help alleviate the need to have two different inhalers. And so this is a drug called Advair. This is a combination. We can also use antibiotics when these individuals get bacterial infections like bronchitis or pneumonia. We want to use antibiotics so that they don't become sicker, right? Want to try to keep them out of the hospital if at all possible. So from the nursing perspective, when we're talking about pulmonary rehabilitation, one of the most important things that you can do is to help teach these patients breathing exercises and techniques that can help reduce the shortness of breath and discomfort. So pursed lip breathing is one of these techniques. You want to teach the patient to relax the neck and shoulder muscles. Breathe in for 2 seconds through your nose, keeping your mouth closed, and then breathe out for 4 seconds through pursed lips. This is something that they can practice and they can get better at, and they can find that it is helpful. The longer exhale might help them get some of that trapped air out of the alveoli. The other thing are some some positions to reduce shortness of breath. We can see here we've got the tripod seated position. Oftentimes that position where you're kind of leaning forward can be very helpful. We can see an upright seated position here. There are other positions we can use as well. We see the gentleman standing up against the wall position. We can see the standing tripod position there. These are all possible positions that could be helpful. I want you always to remember that if you are taking care of a patient in a hospital or a long-term care setting and they become short of breath, the first intervention that you want to do is what? What? What are you going to do first? Make sure you raise the head of the bed up to a high Fowler's position, and then what's the next thing you're going to do? You're going to check their SpO2. You're going to do a lung assessment, and you identify that their SpO2 has dropped below 95%. What are you going to do next? You're going to give them oxygen. Do you need an order to put them on oxygen? No, you do not need an order to put them on oxygen. You can put them on 1 to 2 liters, have them take some deep breaths in that nice high Fowler's position, check their SpO2 again, and see how they're doing, right? And then we can follow along with all of our other options, right? We might need to use an albuterol inhaler. We might need to do an albuterol treatment with a DuoNeb, right? And so we could be moving through our asthma action plan, right? Or moving through whatever other plan we have in place when we have a person with COPD who's having some difficulty breathing. Okay, so those are really important things to keep in mind. For nutrition therapy, these folks early in the disease might need to lose some weight. Late in the disease, in emphysema, often they need to gain weight, so they're oftentimes underweight. And so nutrition is going to be very important, whether it's to get them at a healthier weight through losing weight or gaining some weight. Supplemental oxygen, which we've talked about, right? Many of these folks need oxygen 24 hours a day. Sometimes they have home oxygen machines and portable oxygen tanks that they can take with them on the road. And so these are important that we teach them how to utilize these apparatuses. And then vaccine recommendations, right? They should be getting a flu shot every year. There's pneumococcal recommendations, Tdap and zoster. So for pneumococcal, and these are the current recommendations, and they may have specific recommendations in some of the long-term care facilities where you're working. We want to be administering doses of this, should be given at 65 years or older, a specific type, the PCV13, and then the final dose, the PPSV23 at 65 or older, should be given at least 1 year after the PCV13 and at least 5 years after the most recent dose of the PPSV23. These are the current recommendations. The other thing is for the Tdap booster every 10 years. People of all ages need to be vaccinated against whooping cough, and also for zoster or shingles. We want to make sure there are 2 types of zoster vaccines. There's 2 doses for those 50 years or older, or there's one dose that they can take of a certain type at 60 or older, even if they've already had the shingles. So we know that shingles can be very painful. It can also land these individuals in the hospital as well. And so it's important to educate our patients about what vaccines are necessary for them if they have a chronic lung disease. I hope that you learned something today that's helpful for you to take into your practice, to take into the clinics that you're working in, so you can help these individuals live the best quality of life possible. That is our goal as nurses, that even though we care for people who have chronic diseases, we are doing our best to maximize their quality of life. Thanks for your attention today, and I will see you next time. Aloha.